Late one night in January, a woman calls the police because she can see intruders in her home. She can see several men moving around inside there. And so on the phone call, on the 911 call, they suggest that she waits outside. She says, in fact, she's been outside for some time, hoping they'll steal whatever they want and leave her home. But this is Canada in January. It's minus 20 Celsius out, the wind is biting, and this woman is literally curled up in a snowbank beside her driveway. The police arrive and find her there, but the house is locked up tight. There's nobody inside, and the woman is hallucinating. And so they call an ambulance and bring her to you. When you first see her, she is so pale, she is actually blue. And she's got a core temperature of 28 Celsius. Her systolic is 60, her GCS is 11. She is protecting her airway and she's breathing, so we put IVs in and start warmed fluids. We cover her with warming blankets. We give her some push-dose pressors while we're waiting for her norepi to get connected. I page the ECMO team to see if they'll put her on a circuit to rewarm her. And I'm just talking to them on the phone when she starts to vomit. And she's vomiting massive amounts of bright red blood. Chainsaw massacre bleeding. And that's what we're going to talk about. Bedside resuscitation of overwhelming GI bleeding. Now at this stage, her GCS is now 10. She's starting to aspirate with all of that blood. Her SAT is dropping, so airway moves to the top of our priority list. Anatomically, her airway looks easy, but physiologically it looks awful. So we double down on our resuscitation to try to get her stable enough to survive laryngoscopy. We start our massive transfusion protocol and stop all of the crystalloid. We're still actively rewarming her because bleeding at this core temperature is dangerous. With severe hypothermia, your clotting factors will not work. We prep for a double setup. Somebody marks the neck while I put an endotracheal tube on a bougie, and we're running her on high-flow nasal cannula at 100%. We assign roles and we pre-brief. We give somebody the job of just suctioning her, and we set up 4 suctions for them to use. Now, for me, when I intubate, I like to have normal vital signs for my patients, but I'll tolerate a SAT of 90 and a systolic of 90 if that's the best I can get. For this lady, I couldn't get either of those. So I settled for a SAT in the 80s and a systolic in the 80s. I don't like settling. This is not my style. But this was the best opportunity we had to get a tube in this lady. We give her ketamine and rocuronium. And I know, rock haters, you're going to give me some feedback, probably right now on Twitter. But we had one shot, we felt, at this airway. And we felt paralyzing her was our best move to not let her cough or vomit and aspirate. It was risky, and we understood that. At my place, we have these suction catheters. They have the little hole in the side. I don't know if you guys have these. We tape over that hole with pink tape so nobody has to keep their thumb on it all the time. And when we have our first look, all we could see was blood in this woman's airway. And so we took the suction catheter and inserted it posteriorly into the esophagus. On purpose, intentionally, intubating the esophagus with a suction catheter so you can suck out that blood and divert flow from across your airway. This is the salad technique as described by Jim Ducanto. But even with the suction catheter in place to suction, we still can't see anything. So we use a bougie to get across her airway, and we can feel the anterior tracheal rings to get tactile confirmation that the tube's in the right spot. We pass an endotracheal tube and overinflate the cuff a little to minimize her aspiration. By this stage, somebody's looked her up in the computer, and we find that she's got a history of alcoholic cirrhosis with known esophageal varices. She also has a history of delirium tremens, which may explain her hallucinations and why she ended up in that snowbank in the first place. We give her octreotide, we give ceftriaxone, we give pantoprazole, we give her tranexamic acid. And with all of this, and warming, and norepi, and the vent, she starts to get better. She's responding to our resuscitation, the heart rate comes down, And we have that first moment of relief that we're catching up to this lady who was so sick. And so I exhale, and I smile at somebody across the room. And then there's this gurgling noise, and she kind of coughs a little, and bleeding, like goddamn Niagara Falls, erupts out of her mouth and splatters the far wall of the room. It was not my finest hour. At this stage, gastroenterology arrives to save me, and they have a quick look with their scope, but they can't see anything. In fact, they can only see this, which is a river of blood, so more terrifying than helpful. They abort, and we're back to medical management, but this lady is still dying with everything we've given her. At this stage, you need a get-out-of-jail-free card, right? You need a rescue device. And so we used balloon tamponade. This is a rare procedure. You will not see this often. So you can't wait to learn it from somebody else's case. If we want to own the resus room, we need to have this knowledge at our fingertips. And it requires 3 chunks of knowledge. You need to know what, where, and how. So first off, you need to know what tube you stock at your place. There are 3 typical options. You could have a Linton tube, which has a single gastric balloon. A Blakemore has both a gastric and an esophageal balloon. And a Minnesota tube has both balloons, gastric and esophageal, but then also an esophageal aspiration port. Knowing which tube you stock helps prevent a critical mistake. And the mistake goes like this. You have a patient with a big GI bleed, and you send somebody to go find the Blakemore tube. But they can never find it because there is no box that says Blakemore, because you stock Minnesota tubes instead. I've made this mistake, and my patient underwent a significant delay because of that. And I can own that and pay it forward by asking that none of you make my mistake. You need to know what tube you stock, and if you're not personally certain, you need to email your stocking person, phone your friend in endoscopy, or just decide on your next shift back that you'll spend 5 minutes figuring it out, and set yourself a calendar reminder so you don't forget. Once you know which tube you have, you need to know where to find it, so you send somebody to the right spot. This decreases the time to get it to your bedside. And last but not least, you need to know how to insert one of these suckers. So let's walk you through the procedure. There are also great videos out there on the internet if you want to review once you know precisely which tube you have. At my place, we have Minnesota tubes with the 2 balloons. And you insert this just like an NG in a blind technique. So start by taking a breath, lower your heart rate, because this is stressful, but not actually difficult. We estimate the distance we want to go by measuring from the patient's ear to their nose to their xiphoid, just like an NG, and we inserted it blind into the mouth. If you prefer, you can use a laryngoscope to view it going into the esophagus. That's also okay. You insert it to the depth that you've measured, typically around 50 centimeters, 50. Once it's there, you put a little bit of air in the gastric balloon, usually around 50 cc's. Then you shoot x-rays to confirm it's in the stomach, below the diaphragm. This is the critical step, in fact, because the main error made with these tubes is not being sure it's in the stomach. This is why we fill it with air, so it makes it more visible on x-ray. Although, if you're an ultrasound wizard, you can also confirm it's there using your ultrasound. That's okay, too. Here's the thing. If you get it wrong and the balloon is too high, and you fully inflate it in the esophagus, you rupture the esophagus, and that doesn't make anybody's day better. So this is the mistake we're trying to avoid. It must be in the stomach. Once it's there, and you're sure, you fully inflate it to a total of 500 cc's of air. If you get it wrong, and you fully inflate it up high, it looks like this. It looks like a big old balloon in the middle of your mediastinum. You never want to see this x-ray, because this mistake is almost uniformly lethal. Please, 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 Make sure the balloon is in the stomach before you fully inflate it. Once it's there and it's inflated, you need to apply some traction. So at my place, we attach it to 1-liter bags of crystalloid. It's super old school, but it works. It's pretty functional. You hang the bag over an IV pole or some metal tubing, and you just let it hang there so that if you change the head of the bed, the same degree of traction is still maintained. And so for my lady, with her gastric balloon inflated, we're now applying traction to press up against the GE junction. This gives you tamponade and is often enough to stop bleeding in variceal bleeds. In my case, of course, the lady was still bleeding. She hadn't stopped yet. So we need to take that next step of inflating the esophageal balloon. We inflate it with about 100 cc's of air, and you can use a pressure manometer to check and make sure the pressures are acceptable. You don't need to worry about remembering the specific numbers, right? All of these tubes come with a little instruction booklet that tells you precisely how to put it in, or if you've lost the booklet, you can readily find these numbers with Google. Although I'll tell you, the best centers that do this attach a 1-page cheat sheet to each of these tubes with explicit step-by-step instructions of how to put them in. And that cheat sheet has a font size that is actually legible by normal humans, unlike the little booklet, which is like size 4 font. But that's an easy KT project for your next medical student who wants to do something with you. This lady's still bleeding. MTP is ongoing. We're actively warming her. Both balloons are up. We're giving her everything we have, and she is still dying. So we decide to phone a friend. We call interventional radiology to ask them if they'll attempt embolization or TIPS. And they say, sure, bring her down. If you're going to travel, though, with balloon tamponade, you need to adjust your setup a little bit, because having traction hanging over a pole is unwieldy in the elevator, and it gets in the way of the radiology equipment. And so we used this trick my paramedics taught me a couple months ago. And the way they do it is they feed the balloon device through the hole in a face mask. They're not using the face mask for oxygen or anything else. And then they clamp it there to maintain the same degree of traction. And this provides a really slick way to maintain your traction on a transport or in an elevator. You just put the face mask right there beside the endotracheal tube to hold it in place. We were about to roll out the door when she stopped bleeding. Blood stopped pouring, the blood pressure came up, her vitals stabilized, and we finally had that moment of true relief. Balloon tamponade saved this lady's life because she would go on to survive her ICU and hospital stay. This is a rare skill. We don't do it often, but it is critical resuscitation knowledge. You need to know what tube you stock, where to find it, and how you personally are going to put it in. 3 easy steps to save a life. Totally worth the 5 minutes of your time. Thanks for listening.